Okay, now we're going to be talking about valvular heart disease. Now this slide basically just shows you the different places in the heart, how blood flow goes, the different valves that are involved, the pulmonic, tricuspid, all the different things. Okay, with valvular heart disease, we're going to talk about mitral stenosis, mitral regurgitation, MVP or mitral valve prolapse, aortic stenosis, and aortic regurgitation. And this is just a little slide that shows about mitral valve stenosis. It's good to look over this. Okay, with mitral valve stenosis, it usually results from rheumatic carditis, which can cause valve thickening by fibrosis and calcification. Rheumatic fever is the most common cause of the problem. In industrialized nations, congenital abnormalities affect the majority of the patients with mitral stenosis. Now, in mitral stenosis, the valve leaflets fuse and become stiff, and the chordae tendae contract and shorten. Now, the valve opening narrows, preventing normal blood flow from the left atrium and the left ventricle. As a result of these changes, the left atrial pressure rises and the left atrium dilates. Pulmonary artery pressure increases and the right ventricle hypertrophies. Now, pulmonary congestion and right-sided heart failure occur first. Later, when the left ventricle receives insufficient blood volume, preload is decreased and the cardiac output fails. Now, people with mitral valve stenosis are usually asymptomatic. As the valvular orifice narrows and the pressure in the lungs increases, the patient experiences dyspnea on exertion, orthopnea, and paradoxical nocturnal dyspnea, or sudden dyspnea at night. They also will have palpitations and a dry cough. Now, hemoptysis, or coughing up blood, and pulmonary edema occur as pulmonary hypertension and congestion progress. And right-sided heart failure can cause hepatomegaly, neck vein distension, and pitting edema late in the disorder. Now, on palpitation, the pulse may be normal, rapid, or irregular if they have AFib. Because of the development of AFib, this indicates that the patient may be decompensated, so the physician should be notified immediately in the development of AFib. Diagnostic for this will be either a chest x-ray, echocardiogram, or EKG. Management with this disease, they'll use drugs, and it depends on the valve that's affected and the degree of the valve impairment. Some patients can be managed on yearly monitoring and drug therapy, whereas others require invasive procedures or heart surgery. So diuretics, beta blockers, digoxin, and oxygen are usually administered to improve the symptoms of heart failure. Nitrates are administered cautiously with patients with aortic stenosis because of the potential for syncope associated with a reduction in the left ventricular volume or preload. Now, vasodilators such as calcium channel blockers may be used to reduce regurgent flow for patients with aortic or mitral stenosis. Now, some non-invasive procedures they can do a balloon valvoplasty. They can also do invasive procedures such as a direct or open commissurotomy, which is accomplished with the cardiopulmonary bypass during an open heart surgery. The surgeon visualizes the valve, removes the thrombi from the atria, and increases the fused leaflets or commissures, and debrides the calcium from the leaflets, widening the orifice. Now, in the mitral valve annuloplasty or reconstruction, uh, reconstruction and leaflet repair result in an annulus of appropriate size and the leaflets that close completely. Thus, regurgitation is eliminated and markedly reduced. Now, valve replacement can be xenograft or human cadavers, and they also could have pulmonary autografts done. Now, nursing care for these patients, you want to teach the patients with valve disease the importance of prophylactic antibiotic therapy before the invasive procedure. You also want to watch for any kind of extubation problems with these people due to the pulmonary hypertension and stiff lungs. You're also going to be aware of they also will have bleeding problems from the site, and so you must maintain a normal blood pressure and heart rate. That is, if they have surgery. Next, we're going to talk about mitral insufficiency. Here's a little slide that gives you some information on that. Okay, mitral insufficiency or mitral regurgitation, as it's called, is basically the fibrotic and calcific changes occurring in the mitral regurgitation, and these prevent the mitral valve from closing completely during systole. Basically, what happens is incomplete closure of the valve allows a backflow of blood into the left atrium, and when the left ventricle contracts. Now, to compensate for the increased volume and pressure, the left atrium and ventricle dilate and eventually hypertrophy. Manifestations you're going to see, mitral regurgitation usually progresses slowly, so patients may remain symptom-free for a long time, for decades. When symptoms do occur, it's usually when the left ventricle fails in response to chronic blood volume overload. And the symptoms are going to include fatigue, chronic weakness as a result of reduced cardiac output. These patients are going to have dyspnea on exertion and orthopnea that develops later. Now, a significant number of the patients report anxiety, atypical chest pains, and palpitations. When right-sided heart failure develops, the neck veins become more distended, the liver enlarges, and pitting edema develops. A high-pitched systolic murmur at the apex with radiation to the left axilla is heard on auscultation. Severe regurgitation often exhibits a third heart sound, such as S3. Diagnostic is going to be the same as for mitral valve stenosis, and treatment and nursing care are going to be basically the same. Now, mitral valve prolapse, basically the etiology of that is variable and has been associated with conditions such as Marfan syndrome and also other congenital cardiac defects. And you can look up Marfan syndrome in your books. Mitral valve prolapse also has a familial tendency. Usually, however, no other cardiac abnormality is found when that's the case. Now, mitral valve prolapse occurs because the valve leaflets enlarge and prolapse into the left atrium during systole. Now, this abnormality is usually benign and may not progress to be pronounced or mitral regurgitation. Manifestations, most patients you're going to see are asymptomatic. However, some report chest pain, palpitations, or exercise intolerance. Now, chest pain is usually atypical, with patients describing a sharp pain localized to the left side of the chest. These patients also complain of dizziness, syncope, and palpitations, and these can be associated with atrial ventricular dysrhythmias. Now, a mid-systolic click and a late systolic murmur may be heard at the apex of the heart. Diagnosis, treatment, and nursing care is the same as the other valve problems. Now we're going to talk about the aortic side, and here's a little slide that shows you some things going on with aortic stenosis. Now, aortic stenosis is a congenital bicuspid or unicuspid aortic valves. These are usually the primary causes for aortic stenosis in many patients. Now, rheumatic aortic stenosis occurs when rheumatic disease of the mitral valve and develops in young and middle-aged adults. Arteriosclerosis and degenerative calcification of the aortic valve are also major causative factors in older adults. Now, aortic stenosis has become the most common valvular disorder in all the countries with aging populations. Now, in aortic stenosis, the aortic valve orifice narrows and obstructs the left ventricular outflow during systole. Now, this increased resistance to ejection and afterload results in ventricular hypertrophy. As the stenosis worsens, cardiac output becomes fixed and cannot increase to meet the demands of the body during exertion. So symptoms then develop. Eventually, the left ventricle fails, blood backs up in the left atrium, and the pulmonary system becomes congested. Right-sided heart failure can occur late in the disease. Now, the classic symptoms of aortic stenosis result in fixed cardiac output, dyspnea, angina, and syncope during occurring on exertion. Now, when the cardiac output fails in the late stages of the disease, the patient experiences marked fatigue, debilitation, and a peripheral cyanosis. A narrow pulse pressure is noted when the blood pressure is measured, and a diamond-shaped systolic murmur is usually noted on auscultation. Diagnosis is usually the same. Now, treatment, usual surgical therapy is the only definitive treatment for aortic stenosis, and is recommended when angina, syncope, and dyspnea on exertion develops. And nursing care is going to be the same for all the valvular problems. And this just goes over some of the treatment for people that have aortic stenosis, depending on their age and their condition. Next thing we're going to talk about is aortic insufficiency. This slide here shows just some facts and different things about aortic insufficiency, or aortic regurgitation, as it's also called. So aortic insufficiency or regurgitation usually results in non-rheumatic conditions such as ineffective endocarditis, congenital anatomic aortic valvular abnormalities, hypertension, and Marfan syndrome. And this is a conductive tissue disease. Now, in patients with aortic regurgitation, the aortic valves leaflets don't close properly during diastole, and the annuals, or the valve ring that's attached to the leaflets, may be dilated, loose, or deformed, and this allows flow of blood from the aorta back into the left ventricle during diastole. The left ventricle is in compensation dilates to accommodate the great blood volume and eventually hypertrophies. Now, manifestations: patients with aortic regurgitation usually remain asymptomatic for years because the heart makes up for the left ventricle. As the disease progresses and the left ventricular failure occurs. The major symptoms are exertion, uh, dyspnea with exertion, orthopnea, and proximal nocturnal dyspnea. Now, palpitations may be noted with severe disease, especially when the patient lays down on the left side. Nocturnal angina and diaphoresis often occurs with these patients also. And on palpation, the nurse is going to note a bounding arterial pulse. The pulse pressure is usually widened with an elevated systolic pressure and diminished diastolic pressure. Now, the classic auscultatory finding is a high-pitched blowing decrescendo dystolic murmur. Diagnosis is basically the same, and treatment is the same as aortic stenosis. And nursing care is the same as all valve disorders. Now that's it for valvular disorders. Next up is going to be congenital heart defects.